What's going on, everybody? Welcome to episode 177 of the Core Consult RX podcast. We are back at it, boys. We got another episode that is going to be ACPE accredited, thanks to our friends over at freece.com. So, for those of you who are already members of FreeCE's portal, make sure you go on to their website, freece.com. The link will be in the show notes as well. And you can, after you listen and you learn all about these new medications we're going to talk about today, you can go on their website and do the post-activity test. After you score an easy 100 on that, it'll give you 1 hour's worth of continuing education credit for pharmacists and nurses. And if you are not a member, there's going to be a discount code for their annual, unlimited membership fee. It's a one-time fee for the year, and there's be a discount code in our show notes as well. So make sure you check that out. And for this activity, make sure you use the password approved in all caps. So APPROVED, all caps, and that'll get you into the post-activity test. And then you'll get your credit. So we're pretty excited to do this episode. We've been talking about doing something like this for a while, so we figured this would be a good one for continuing ed credit.
Yeah.
We're going to basically just cover some of the new drugs that have been FDA approved over the last year or so.
And these are all novel therapeutic agents. So this wouldn't include biosimilars or new FDA indications and that sort of thing, right?
Yep. And I think we actually, for time's sake, just because there's been quite a few meds, we left out a lot of the oncology meds and more specialized things, but some more specialized things we're still going to discuss. But these we try to pick the drugs just that'll be as applicable to as many people as possible.
I feel like we did an episode like this the first couple years, but I don't think we did. We haven't done one in a while, right?
Yeah, no, it's been a while.
It's good.
Yeah.
There's always new drugs coming out.
Absolutely,
I'm
excited.
And there's some good ones in here.
I agree. I think so too. And some of these may be, old news for you, hopefully.
Yeah, but, I mean, if it's in the last year, you've probably heard of it, but we're going to give you a little more info if you have not.
Emphasis on a little bit. Now, and also, too, before we get started, I definitely want to thank our friends over at pearls.com. We just renewed a contract with them, and they're going to be another kind of our main sponsor going forward. So huge thanks to them. They help us kind of keep this going. And they actually just dropped, the time we're recording we're recording March 31st, but this will be released in a few days. They just released a new dyslipidemia treatment guideline today. It's a whole chart flow algorithm that kind of allows you to go through the different treatment options based on the 2018 guidelines. It fits very nicely with our other accredited episode on treating or managing dyslipidemia. So definitely go there. The email address, the URL rather, is pyrls.com/coreconsultrx. You can sign up for a free account and you'll get access to various charts and drug info. It's basically LexiComp with a very nice aesthetic to it. And the pharmacist, Eric, that's putting that together has made a ton of improvements. It's a really, really cool program, so make sure you check that out. All right. Where are we starting, Cole?
I think we're going to start with so there's going to be a lot of weird pronunciations. I feel like we've had a few episodes like that. Probably starting with the weirdest drug name of them all, I think. The brand is Brexafemme, which is fine. The generic is ibrexafungerp, which sounds like a typo, but it's not. So what this is a single-day oral antifungal, specifically a triterpenoid antifungal. So what it's used is for uncomplicated vulvovaginal candidiasis in females. Unlike fluconazole, which inhibits fungal growth, this kills Candida species by inhibiting formation of the fungal cell wall. And it's considered novel because it would be the first in its class that does that. The way it's dosed is kind of similar as far for this indication, kind of like fluconazole. It's a very short course. So it's just 4 tablets of 150 milligrams each. They take 2 tablets twice in a day, 2 in the morning, 2 at night, and that's it. And that would be the dose for this. It does have drug interactions like you would expect with antifungals. Strong CYP3 or 4 inhibitors. You want to reduce the dose to 150 milligrams twice a day. And then other strong or moderate CYP3 inhibitor inducers may have significantly reduced exposure, and you should avoid the co-treatment with this one. Don't use it in pregnancy or lactation, so we do have some special considerations there. There is a concern for fetal harm from animal studies, so don't use it in that. Pricey as you would expect. For the 4 tabs, about $570. Not super unreasonable for insurance to cover, but definitely more expensive than fluconazole. Generally well tolerated. Adverse effects of abdominal pain, diarrhea, nausea, and it covers the majority of the Candida species, except for Candida krusei, but it does cover all the other ones. So in general, the main prohibitive thing would probably be the cost, but otherwise it seems like a reasonable thing to use. Why would you use this instead of fluconazole?
I mean, my initial thought was basically fluconazole treatment failure. Yeah. However, at that point, you would want to make sure that your differential diagnosis was correct in the first place, because it could be the vaginal symptoms could be from trick or something like that, and so you'd want to make sure that it could be resistant Candida species that's causing it. But I think we'll have to see how often. I haven't seen anybody actually get started on this yet myself, so I think that the coverage is much better potentially as far as the species that it covers, because it's going to cover glabrata and all that. But I don't know how applicable this is going to be to primary care setting because of the cost.
And that'll be a trend with these new drugs that we talk about. We're probably going to say, I don't know how much it's going to be used because of cost and that sort of thing. But, they're new drugs that come out. Eventually they will be cheaper. And I'm sure they will serve a purpose in the short term with, resistant cases of things and that sort of thing.
Yeah. So the next one, I think, is definitely going to be a solid option despite the cost, and hopefully more insurance companies will kind of add this to formulary because it's probably got some of the best data that we've seen, specifically in weight management pharmacotherapy options, because we're kind of limited in that space. We did a whole episode on those, and you kind of see that the data is not that impressive when you see how much weight loss you would expect. So the new kid on the block is Wegovy, is the brand name. Now this is actually just a higher dose semaglutide. So just like what Victoza did with Saxenda, this is Ozempic, but a higher dose, and so they under the brand name Wegovy. So when it comes to this is basically indicated for weight management specifically. So it doesn't have to be someone that has diabetes. And we've talked about this many times in the past about GLP-1s, but one of the good and safety benefits of a GLP-1 versus something else, like insulins or whatnot, that we use in diabetes is the fact that the hypoglycemia risk is significantly lower because they tend to only release that or cause that insulin release and glucagon suppression when a patient consumes a carbohydrate-rich meal and their blood sugar starts to go up. And so in the case of GLP-1s, in a patient who doesn't have diabetes, you can still use them safely because you won't get the same glucose lowering effect that you would with someone that has diabetes. But you'll still get the decrease in gastric motility, and you'll still get the decrease in appetite based on suppression in the hypothalamus, or I should say activation of those neurons. AJ, what's the term?
Pro-opiomelanocortin neurons.
AJ's favorite term ever. And so when you increase the firing of those neurons in the hypothalamus, you can also affect appetite and satiety after a meal. So again, it's a little bit higher dosing, and it's indicated specifically for patients who have a BMI of 30 kilograms per meter squared or greater, or you can back that down a little bit, and they can be 27 or more for the BMI if they have one or more weight-associated comorbidities such as hypertension or dyslipidemia. And you are going to still need to titrate the same way, and it takes a lot longer to obviously reach the target dose of 2.4 milligrams than it would the 1 milligram like you would with Ozempic. But it's definitely something you want to kind of follow the titration schedule because serious GI upset, nausea, vomiting can happen if you go too quickly. So for the first 4 weeks, you're doing that 0.25 milligrams weekly. It is dosed weekly just like the Ozempic would be. And then the next 4 weeks, you're going up to 0.5 milligrams once weekly. And then weeks 9 through 12, you're doing 1 milligrams once weekly. And then this is where it starts to increase more than Ozempic. And the next 4 weeks, you're doing 1.7. And then week 17 and thereafter, you're doing 2.4 milligrams a week. And obviously, if it's not tolerated, you can go back down at any point and sort of readjust them, because there are going to be patients who need longer at those certain doses to get their GI system acclimated to being on this. And some people can't ever tolerate going up too high. So I haven't had anybody specifically on the higher dose, the Wegovy itself, but we've definitely used Ozempic kind of off-label for this particular reason. And so it'll be interesting to see how many insurance companies will kind of carry it. And the reason I'm a little bit more hopeful for this one as far as it getting on to formularies is because the data is pretty significant. So the STEP trials were the ones that were kind of assessing the efficacy. And to give you examples, the STEP 1 trial was the semaglutide versus placebo, and both groups had lifestyle interventions. So the mean weight loss was greater in the semaglutide option, or the group, obviously, but they lost 15.3 kilograms from baseline compared to 2.6 with placebo. So, and that's a 68-week period. So that's quite a bit of weight loss. And that's kilograms as well. And so the other one that was done, there's multiple studies that were done, but another one that we'll talk about is the STEP 3. That only had 611 patients, but and basically they did more intensive lifestyle intervention and an initial calorie restricted diet, and that's what they kind of were looking at comparatively with semaglutide, and you see that the same kind of results are echoed. Adverse effects, though, the GI and nausea, vomiting are always going to be the bigger, issues with those GLP-1s, unfortunately. So, you have to make sure that we're going slowly and escalating appropriately, or even slower if we need to. And then thinking about things as far as before getting started. So if they have a history of pancreatitis, or they have a family history of medullary thyroid cancer or multiple endocrine neoplasia type 2, you cannot use these. Gastroparesis would be another reason to probably hold off on starting something like this. But and pregnancy as well, because we don't have any good data in that group yet. But definitely probably the strongest weight loss data that we've ever seen from a medication. So I think this is definitely one to watch.
Yeah. Sadly, it's not on a whole lot of formularies, even compared to other similar drugs, similar GLP-1s. Yes.
Cole's a half-empty kind of guy.
I am. And sadly, they do not have a patient assistance program like some others. They have it's from Novo Nordisk, but Novo Nordisk does not do it for this one, only for the diabetes medications. They do have a copay card that can be used even if a patient doesn't have insurance to cover $500 of the cost. There's probably a limit on uses on that, but I don't know exactly what it is. But yeah, it's the alternative would be to use, which I have seen, is Ozempic off-label.
And I'll give you a little kind of hint as well. If you're in the 340B space, Ozempic significantly decreased its price for 340B pharmacies. Significantly. And so it's something that if you have a patient who you're trying to kind of titrate the dose up, but you're stuck using Ozempic because that's the only thing that's somewhat affordable, you obviously could do 2 injections of the Ozempic to kind of increase that dose appropriately. Obviously, that's going to be up to your clinic and what kind of policies you have in place, but that's one workaround that you could kind of entertain. So
you think tirzepatide's going to take its place? It might not have the indication for weight loss, but it's going to have better weight loss.
Yeah, right? I think it might, and I think I've heard some rumors, some whispers, if you will, that tirzepatide might be approved this year, by summertime. Yeah.
Very interesting.
Very interesting.
Okay. Is that all?
Don't hold me to that, but that's what I've heard.
Is that all for Wegovy?
That's it.
All right. So the next one is a pretty hot one. I guess it was, 7-8 months ago when it first came out. Aduhelm, Aducanumab. You've probably heard of it because it was all over the news. Very controversial. It is an anti-amyloid monoclonal antibody approved for the treatment of Alzheimer's disease. In particular, patients with mild cognitive impairment or mild dementia stage of Alzheimer's disease, with a few criteria. The criteria are an MMSE, mini mental state exam, greater or equal than 21, a MoCA, greater than or equal to 17, which is another memory test. Also, patients proven to be amyloid positive. They do this through an amyloid PET scan or a lumbar puncture, more frequently seen lumbar puncture. Also, they have to not be high risk for hemorrhagic adverse effects. So risk factors would be greater than 4 microhemorrhages on an MRI, areas of superficial siderosis, things like that. And we'll get to why that is. Also consider checking for an apolipoprotein E epsilon 4, so an ApoE E4 allele, because the side effects could be worse. So the whole idea is that it's going to reduce amyloid beta plaques, which we're all pretty familiar with being a significant culprit in Alzheimer's disease and what causes the problems. I won't get into the whole controversy now, but effectively, the data wasn't as strong as you might like, and then it was kind of expedited through the FDA approval. So there were a lot of docs when it came out who were very hesitant. Not only that, it's really, this is reflected in the approval too, it's really only intended for patients who are in a very, very early mild stages of Alzheimer's. And so later stages, patients who are more severe, really not indicated for them. And so the benefits probably would not outweigh the risks in that instance, and it's up to the patient and the physician whether the benefits outweigh the risks in general. I've definitely heard some neurologists not speak kindly of it, but I digress. So as far as side effects go, amyloid-related imaging abnormalities, ARIA, are reported in approximately 40% of the patients who were treated with the highest dose of this. The risk is higher in the patients with that ApoE4 allele. It most commonly occurs within the first 8 doses. ARIA, man, I can't say that. Edema has a similar pathology to reversible posterior leukoencephalopathy syndrome, which is something that typically resolves over time without complications. But they can also have an ARIA microhemorrhage, which would be like microhemorrhages and or superficial siderosis. Patients need to be monitored for symptoms of these things by a family member, and a brain MRI is required prior to giving the 5th, 7th, and 12th doses. I should mention that it's an infusion, so this is not a sub-Q injection, it's not a tablet. This would be an infusion that a patient would have to get, and it is, of course, very expensive. So there were a couple of trials that were responsible for its approval, or at least for the data that we have on it. One is the EMERGE trial. Long and the short of it is high doses had less clinical decline from baseline compared to placebo. So that was kind of as positive as we can get about it. The ENGAGE trial, the CDR sum of boxes scores were not different between groups, and no benefit was seen for most of the secondary outcomes. So this was not a positive trial for it.
Hey, 50%, not bad. Let's approve it.
1 for 2?
Yeah.
Let's go. I think, was it 2? I think 2 doctors on the FDA advisory committee resigned after it was approved, right?
Yep.
So there's other adverse effects: headache, falls, diarrhea, confusion. 0.6% of patients developed aducanumab antibodies. It was unknown if they were neutralizing. Overall, I mean, my non-professional opinion would be use with caution.
Yeah.
If used at all.
Yeah, I agree.
But until we get more data, I think the hemorrhage situation is what most people are concerned about.
Yeah, and I mean, plus you got to think the cost. I mean, and it's something that there's some, now they got that transdermal, the Nepazil, and so it's like there's some other options they have, and even those don't have great data.
Right.
But
they had the other patch. I can't recall the drug in it, but I mean they have been using a patch for memory previously. But yes, that was the first transdermal donepezil.
So yeah, I think it's one of those things that we'll see how it plays out, but I'm not super hopeful for this one. I hope they have some better options coming up. So the next drug we'll talk about is Kerendia, so finerenone. This is something that is approved. It got approved in January of 2022, and it's approved to use in patients with type 2 diabetes that have and less severe diabetic kidney disease. So typically thinking, if a patient has diabetic kidney disease, we are going to give them an ACE or ARB, and we also have our SGLT2 inhibitors that have good data with in kidney disease as well. So this is another potential option that we can utilize in that patient population. So finerenone it's a mineralocorticoid receptor antagonist, and so think of it as somewhat similar to like one of our spironolactones or something like that. And it's there to kind of continue to preserve the kidney function, and it's one of those things that it's an add-on to someone who's at least established on an ACE or ARB, and then in most cases, an SGLT2 inhibitor as well. It does have some renal dose adjustments. So an EGFR of greater than 60 or more, you just do the 20 milligrams once a day like normal. And then the 25 EGFR of 25 to 60 mils per minute, you're going to drop it to 10 milligrams. And then if it falls below 25 mils per minute, we're not going to be using this. And then maintenance dose is determined basically by serum potassium. So you measure it 4 weeks after initiation of therapy, and then you may end up having to adjust based on the potassium level because obviously it has a potassium sparing effect. So let's just say if the patient's potassium is 4.8 or less, then you're on 10 milligrams once a day, then you can increase to 20 milligrams once a day, and then if they're already on the 20, you can just continue. If it's greater than 4.8 up to 5.5, then you would want to keep them at a 10 milligram dose. And if they're on 20, you can continue from there. If it's greater than 5.5, you'd want to interrupt therapy and then may consider restarting at the 10 milligrams once the serum potassium falls back below 5. And then same thing with the 20 milligrams. So potassium, accumulation is definitely something that we'd have to worry about. But the thought process is basically that it's kind of helping to reduce albuminuria and also, kind of prolong, like I was saying, the life of the kidney. So they were looking at things like the end stage or time to end stage kidney disease and all that. And so some of these were not as impressive as like the reduction in albuminuria. And again, the cost is going to be an issue because this has been kind of like it's still new. So whether or not it's actually on formularies and whatnot, there is a workaround slightly with some of the patient assistance and like copay assistance cards, things like that. But it definitely does not have the huge amount of data that the SGLT2 inhibitors have. So I still feel like a lot of times patients are going to be getting those first added onto their ACE or R before finerenone is an option. But if the genital yeast infections or something like that becomes an issue, then maybe this could be a good option. So the study to kind of look into if you want more information is the Fidelio DKD trial. It had over 5,000 patients, almost 6,000 patients, and all patients were on maximally tolerated dose of an ACE or R at baseline. And it went for 2.6 years, and it decreased the incidence of a 40% or larger decline in EGFR. So, and it non-significantly reduced the rates of all-cause mortality, so that wasn't as good, as well as reaching end-stage kidney disease. So again, slowing that progression of renal function, or slowing the decline of renal function slightly, and then again helping with albuminuria, proteinuria from occurring. So that's kind of the thought process there.
Nice. That's an interesting one.
Yeah.
So the next one is not actually a novel drug. It's naloxone, but an injection. So the brand name is Zimhi. So obviously we have other naloxone formulations under the brand name Narcan. So this is a pre-filled syringe injection. It's latex-free. It delivers a 5 milligram dose in 0.5 mLs. So just like other naloxone products, who would we want to have this medication? Patients who are at high risk for an opioid overdose, right? So some of those might be if they're receiving or discontinuing treatment for opioid use disorder, including medication or behavioral therapies. Patient at risk of decreased tolerance because of recent abstinence, including a release from prison or a medically supervised opioid withdrawal. Also, patients using other illicit medications that they've gotten off the street, like cocaine, methamphetamine. Reason being, they may be laced with fentanyl. So, if the pills are not, if they're, I suppose, counterfeit, or if they're laced with fentanyl, then of course that would result in a possible overdose. So, them having this would be convenient as well. If they, of course, have a suspected opioid use disorder, or if they are prescribed opioids by a doctor, but in certain situations may be at higher risk. So if they have greater than 50 morphine milligram equivalents daily prescribed, if they're also using other sedating drugs like benzos, of course, any other history of substance use disorder, and a history of overdose, they would be good to have this as well. The side effects, if you're using it to reverse the opioid, of course, there could be nausea, there could be vomiting, tachycardia, elevated blood pressure, A lot of times the patients are pretty agitated once you once you bring them back. So anger or dope sickness is not uncommon either. And it's good to note that the reversal of the overdose may be temporary. The drug's half-life is pretty short, so antagonism may wane before the opioids are fully out of the body.
I think this is too. If you compare like the dosing of this, like 5 milligram dose compared to a lot of the other ones that, like the Avizio that we used to have, that auto injector was only 0.4 milligrams per 0.4 mLs. So you're getting a higher dose of the naloxone. And I actually had one of my PA students that was a EMT prior to coming to PA school, and he said that he's had multiple instances where they revived somebody, left the scene. Person went, and then basically the naloxone ran out of their system and was eliminated before the opioid was, and they overdosed again without even adding something else to it. So this, I think, is a way to combat that, especially with obviously like you said, the fentanyl use, accidental overdoses with fentanyl becoming a much bigger thing.
Yeah, so they can literally have a recurrence in their respiratory depression if the naloxone gets pumped out.
And he said he saw that multiple times.
That's crazy.
For the patient. He had to go a second call to the same exact house they had just left.
Wow.
And revive the person
I'm
again.
surprised that's not like an automatic bus to the hospital.
Yeah, I guess.
If you have to deliver Narcan.
I guess
maybe
it's their
not
decision, because they're fine after that.
Yeah.
I mean, essentially, as long as you're monitoring for the withdrawal symptoms,
right,
like you were talking about. But it said, and I think there was several studies of patients basically reversed with naloxone by paramedics and then released without transport to the hospital have found little to no evidence of recurrence of overdose leading to fatality without the opioid still being in their system. So I think that's what they're basing it off of like, hey, if the person refuses to go, that you don't have to take them.
I see.
So definitely an interesting one.
Yeah.
Just for time's sake, we won't spend a lot of time on this one in particular, but
we did talk about it recently.
Yeah, we just talked about this one on our dry eye episode. That one was not accredited, but still, fairly okay. If you want to go take a listen to that one,
check it out.
But the Tyrvaya is the brand name for varenicline nasal spray utilized for dry eye disease. Sounds counterintuitive, but it does have some okay data with it. So I won't repeat what we talked about in the last episode, but check that one out and just be aware that there's a varenicline nasal spray available on the market now for dry eye disease. So the next thing is the PreHevbrio injection, which is a hepatitis B vaccine. It's a recombinant vaccine. So it's another option for giving and vaccinating patients against hepatitis B. It's a novel trivalent Hep B vaccine, and it's going to. It was approved in January of 2022, and it's basically mammalian cell-derived recombinant vaccine that contains 2 pre-S epitopes in addition to the S antigen. And so, compared with conventional hepatitis B vaccines, the vaccine's more immunogenic, especially in older patients. However, as far as like how this is going to kind of fit into scheduling or ACIP recommendations or something along those lines, it's not quite obvious because, yes, you can get a little bit more immunogenicity out of it, especially in our older population, but the adverse effects tend to be a little bit more frequently observed compared to the other 3-dose Hep B vaccine series. And especially with the other version that's available, the 2-dose series, this is a 3-dose vaccine series as well. So there's some concern there that people will end up just wanting to use the I'm drawing a blank on the name, Hepslava. There's the other 2-dose Hepslava, right? Is that right, AJ?
That sounds right.
Yeah.
Sounds good.
Yeah, it's close enough. You guys know what I'm talking about.
Well, I couldn't remember the name of the rivastigmine patch earlier, by the way. That's what I was forgetting. Rivastigmine patch.
Well, and when you said that, I was thinking there was an R or something, but then I'm like, I'm not even going to try because I'm going to butcher it.
I almost said Nupro, but that is not it.
That's something different.
Heplisav.
What did I say?
Hevislava.
Oh, yeah.
Not even close.
I don't know. I think
I was using a Slavic accent.
I think it was a dessert of some sort.
Listen, how dare you guys?
Baklava.
Yeah. Balaclava? No, something different.
Okay, you know what? I'm not podcasting with you guys anymore. And here's the name of it on the next slide that I had made for myself as a reminder, so I wouldn't forget. I forgot that I made that slide. Sometimes I'm kind of dumb, guys. Sorry. Heplisav. How do you say it, AJ?
Heplisav.
Heplisav. I don't like that. That one is that 0 and 1 month dosing schedule versus the the other options that are available are 1, 0, and 6 months. And so it'll be interesting to see how this plays out, especially since you have more adverse effects with this one. It'll be, I think, kind of select patients that are utilizing this.
Yeah. The next one is, I think we've talked about it a while ago, maybe if we were doing a heart failure refresher.
Yeah.
It was a little over a year ago that it was approved, January 2021, but this is Verquvo, vericiguat. It's a guanylate cyclase inhibitor, and it's used for heart failure, specifically HFrEF, reduced ejection fraction. The way it works is cyclic guanosine monophosphate activity is increased, which potentiates the salutary pulmonary artery, promoting vasodilating effects of nitric oxide. There was kind of a big trial that resulted in its approval that had okay evidence, I suppose. They did see statistical significance with their primary composite endpoint that included cardiovascular death, heart failure hospitalization, split between first hospitalization and then total hospitalization, and then death from any cause. So the primary endpoint was statistically significant, but it was driven by the 2 hospitalization outcomes. So we didn't get any good mortality data, so the cardiovascular death and the death from any cause were not statistically significant when they separated those out. So definitely not a game changer in any way. I haven't seen it used. I'm not really sure it has much of a place, but possibly.
Yeah, I tend to think of it as like another one of those like ivabradine or something, where you're getting, maybe if the patient's, on the already kind of standard longevity medications that we think about, the beta blockers, the ACR, ARNIs, maybe spironolactone, and then you start having exacerbations, hospitalization, that's when this might be a good add-on to keep them out of the hospital, but definitely not going to be replacing any of the first-line agents, unfortunately. So the other one that we'll mention, we're not going to go as much in depth with this because we're actually going to have an HIV specialist on in probably the next 3 or 4 weeks to talk more about this, but we'll at least mention it. So Cabenuva is a combination of cabotegravir and rilpivirine. It's an extended release injectable medication. So it's an injectable medication for HIV that you can do either monthly or every 2 month injection schedules. And definitely going to be a very good kind of option for patients who, are tired of having to take a medication every single day to maintain their viral suppression. So they have to do a oral lead-in period of around 1 month, so basically just 20 days or more. You should complete that prior to initiation of cabotegravir and rilpivirine injection, the combo. And then on the final day of the oral lead-in, then you can switch over to the injection. And you're going to do, for the monthly injection dosing, you're basically going to get 600 milligrams of cabotegravir, 900 milligrams of rilpivirine, and that's going to be the one injection that's going to last the full month. And then you just keep doing that once a month. And there's also the every 2 month injection dosing, which for the initiation you do the first injection, and the second injection is administered basically 2 months, or right after the. I'm sorry. The first initiation injection should be given on the last day of the lead-in. So you're giving once monthly for 2 doses, and then you can go to the bi-monthly schedule. So at that point, you can kind of continue that. But the first 2 injections are done month to month, back-to-back months, and then you separate it out from there. And one thing I thought was kind of interesting about this that actually got brought up at this training thing I did for Epclusa, for Hep C, one of the infectious disease docs, because we were talking about Hep C, Hep B co-infections, and one of the infectious disease docs brought up a good point, because a lot of times you'll have patients that have HIV, and then they're also co-infected with hepatitis B, but historically, the overlap in therapy has been there where, tenofovir, alafenamide, for example, can be used to treat hepatitis B and keep it suppressed, whether it's for a period of time or, for an extended period of time. And that was also usually a big major backbone of a lot of our HIV therapies. Well, now that patients are switching from that over to this Cabenuva, you could get a flare-up of their Hep B if all of a sudden you just take away the tenofovir component. So if you have patients that are co-infected like that, that needs to be obviously considered, and making sure that if the patient does have certain risk factors and whatnot, you are screening for Hep B when you switch them to make sure that you're not going to cause a flare of Hep B. So he was saying he was like very concerned about that because he had already seen one patient have experienced that.
Oh, interesting.
So something I wasn't really thinking along those lines, but since he brought it up, I thought that was a really good point.
Yeah, I mean, that's a pretty important drug. I mean, especially with how important adherence is with HIV.
Absolutely.
Very important. So, yeah, we'll get more into that when we have that guy on. So the next one is pretty interesting as well. Maybe not as well known, but it's called Evkeeza, evinacumab-dgnb, but evinacumab. So what it is it's an anti-lipid agent. Kind of a unique mechanism of action. It is a monoclonal antibody, but it inhibits angiopoietin-like protein 3, abbreviated ANGPTL3. I don't think there's any good way to say that. It's approved for homozygous, specifically homozygous familial hypercholesterolemia. It's in an IV infusion that's given every 4 weeks, which is kind of inconvenient as far as IV infusions go, but given every 4 weeks. It doesn't really have any dose adjustments with renal impairment, but I would say use caution in severe impairment. Hadn't really been studied. So the study that got it more or less approved is the Ellipse Trial, the Ellipse HOFH phase 3 trial. Small study with 65 patients who had homozygous familial hypercholesterolemia. They all had stable lipid-lowering therapy, so they were receiving a statin, ezetimibe, and a PCSK9. So this would be like if a patient was still not seeing enough lipid lowering from also being on a PCSK9, which most patients do unless they have this familial hypercholesterolemia. So they either got the IV evinacumab or placebo every 4 weeks. The baseline LDL was 255
on therapy.
Despite these therapies. It's just absolutely crazy. Mm-hmm. At week 24, so they did a 6-week study. The percent change from baseline in LDL, 6-month study, yeah. Sorry. The percent change in baseline of LDL was a 47% reduction from the infusion group and then a 1.9% reduction in placebo. Statistically significant, obviously. Pretty good.
Pretty solid.
So as far as a milligram per deciliter decrease, it was 132, I believe, was the absolute difference, which is pretty significant. But at least a 50% reduction, which is, I mean, fantastic after already being on all of those medications. Adverse events was pretty similar between the two groups. Nothing of note, I would say.
They did mention, just to throw this out there, they did mention the 2 serious adverse events. There was a urosepsis case and a suicide attempt, which I don't think that they're necessarily able to draw those, right. But they did note that in the author's kind of comments. So
right. It's good
just to throw that out there.
But as far as I know, I mean, this is kind of the only option we have post PCSK9, right? That you can think of. Yeah,
the new we'll get
into
injection.
We'll get into a different one for heterozygous. I don't know that it matters too much. This one is specifically indicated for homozygous, but yeah.
Yeah, the very infrequently seen is why the patient population in the study is very small.
Yeah, 65.
It's hard to enroll patients to
very small study.
It's crazy that on all that therapy, their LDL was still that high.
Crazy.
So just to kind of mention a couple other things real quick. Just for time's sake, there's a couple new ADHD formulations that have been available now. There's the one in particular that we'll mention is the combination of dexmethylphenidate and serdexmethylphenidate capsules. So it's a combination of those two things. So you have basically 70% of the total concentration is made up of the serdexmethylphenidate, which is just a prodrug of dexmethylphenidate, and then the other 30% is the pure dexmethylphenidate, which is the D-enantiomer of methylphenidate. So think of it as like Focalin with an extended release kind of thing, which is already kind of extended release. So the point of it is basically to last as long as possible, and so you get a little bit more of a prolonged effect from the dose, so that you're not having to take multiple doses, hopefully in theory, and so the onset of action is usually within 1 hour, and typically thought to last around 13 hours. But it's approved for ADHD, and it's got a few titrations, kind of recommendations. So they want you to initially start off with where you're using the 39.2 milligrams of the serdexmethylphenidate and then 7.8 milligrams of the dexmethylphenidate. And you do that for 1 week, and then you can increase to the 52.3/10.4 with a maximum dose kind of sitting around at that same, at least the labeled max dose is there. And then it says a dose reduction or discontinuation may be needed for paradoxical aggravation of symptoms if that does occur. And then if you have a patient who has been on methylphenidate for a while, it may be a good trial to basically discontinue other methylphenidate products and then try this one. Still have to use the initial titration schedule, and you're not substituting like on a milligram per milligram basis. So you still would want to start with the lower dose and work your way up, just because it is going to last longer. That's probably the one that you'll see utilized more often. There's been a couple other things. There was a transdermal formulation available as well of a dextroamphetamine, but this is the one that's probably got the most unique difference from what's already available.
Yeah, very interesting. So the next one I don't fully understand, I suppose, but this is going to be for an antipsychotic for bipolar 1 and schizophrenia. It's a combination pill called Lybalvi. It's got olanzapine in it, which of course is not new, but it is combined with samidorphan. Mm-hmm. Samidorphan is an opioid antagonist, and then of course it's combined with olanzapine, a second-gen atypical antipsychotic. Reason being, not entirely sure. I don't know if you can shed some light, but it's used for bipolar 1 and schizophrenia. The samidorphan can help with the weight gain associated with olanzapine. I don't know if that's the primary reason it's in there.
So basically, the thought process is a lot of the comparative studies have shown that olanzapine tends to actually be more efficacious, and I think a lot of the studies that I'm thinking of that had the comparative were with schizophrenia specifically. So olanzapine does seem to be a very potent and efficacious second-gen antipsychotic versus some of the others. But it's the metabolic syndrome side effects that become such an issue. The dyslipidemia, the glucose intolerance, the weight gain. It makes it one of those drugs that a lot of times we shy away from, especially if they have comorbid issues with cardiovascular disease or whatnot. So the thought process is we can still utilize the olanzapine, and the samidorphan is there to combat the side effects of that, so that we can basically utilize this better agent, at least in theory. I don't know that this one has been compared to, I haven't seen anything where it's been compared directly to other agents without any other active, ingredient other than just the standard therapies, but in theory it sounds like
I like the idea of that
option. Yeah,
I like it now that I understand. That's kind of what I thought, but I didn't know if there was something else to it. So that's good. I like that, and it blocks the mu opioid receptors, which is how it's going to kind of help with the decreased weight gain. But for patients who use opioids, you have to use caution, and they have some instructions. I won't go into all of it, but effectively delay the initiation of the drug for a minimum of 7 days after the last use of a short-acting opioid, 14 days after the last use of a long-acting opioid, and they give some more specifics as well. It can be used adjunct to lithium or Depakote. They have some dose adjustments there as well. But generally, I mean, it sounds like it's just olanzapine plus this opioid receptor, which not a bad idea.
Yeah,
I think that's a little innovative.
Yeah, for sure. I'll have to contact our buddy Patrick Casey if he's seen this come through at all.
And they still, I mean, the drug together is still going to have the side effects associated with metabolic issues, increased triglycerides, weight gain, all that stuff.
It's definitely not going to fix it completely.
Glucose, right. So hopefully it would just be a little less so versus plain olanzapine.
So another one that's kind of definitely going to be, I would imagine, utilized and incorporated into new guidelines coming probably in the next 6 months or so is the Tisbeyer Injections. It's a monoclonal antibody used for asthma. And so this is a new class of medication that we have available now. It's a thymic stromal lymphoprotein, or poietin rather. I'm sorry, can't pronounce words again. And this is something that, when we think about our standard, inhaled corticosteroids, our LABAs, maybe the LAMAs added in as well. Once it comes down to adding, some of these more these monoclonal antibodies or interleukin inhibitors and whatnot, it kind of comes down to, does the patient have an elevated eosinophil count? Do they have other risk factors? Are they on oral corticosteroids? Are they do they have a positive skin prick test? Things like that. So that's how we've in the past kind of differentiated between using some of these other biologics or like Dupixent or Xolair or something like that. This is an option that is basically a subcutaneous every 4-week treatment that can be added on to patients who are already kind of on standard therapy, but it doesn't have a minimum baseline level of blood eosinophils and some of those other markers that we're looking for. And so you can kind of add this on almost like a potential option to, instead of like Spiriva added on, the LAMA added on is another option. This can be added on in place that seems to be pretty fairly effective. It was studied in patients that had an elevated eosinophil count as well as a normal eosinophil count. And the Navigator study was the big one, and it basically reduced asthma exacerbations. And when you added it to their standard therapy, the cost probably will be a little prohibitive, especially at first. But it's the thought process is you're going to get a little bit of benefit by adding this one on as far as cutting down on those exacerbations, hopefully hospitalizations and increasing quality of life over time. But we also got the change from baseline and pre-bronchodilator FEV1 was greater in the treatment group thing compared to placebo. Not really any adverse effects though that were something that stand out. It wasn't that bad as far as patients tolerating it, so could be another good add-on therapy, especially if they're already on standard therapy and you've done all the right switching and escalating dosing and whatnot, and they're still having symptoms. There's also a couple other studies happening right now. There's like the extension study, which is evaluating the safety and tolerability of Tisbeyer in adults and adolescents with severe uncontrolled asthma. I'm sorry, not that's an extension study of an original study. So it's called the Destination Trial, not the extension trial. I'm sorry. And then there's also the Source trial that is looking at the patients that are taking oral corticosteroids daily, and so hopefully reducing the need for those. So kind of like a Dupixent type of situation.
Interesting.
Yeah. So another class.
Yes. The next one we have, which we already referenced previously, is going to be used for lipid lowering. It's called Leqvio, I suppose. You don't usually see a V followed by a Q.
I like it.
It's unusual. Inclisiran. So this is an injection. We mentioned that this might be the other option versus the Evkeeza infusion. This one's a little different, and you'll see why when I talk a little bit about the studies. But as far as how it works, it lowers lipids by a small interfering ribonucleic acid agent. So it's an siRNA agent, but that's what it's doing to be an anti-lipemic to reduce lipids. So the way who this would be used in is not homozygous familial hypercholesterolemia. This would be heterozygous familial hypercholesterolemia. And also, it does have an approval for secondary prevention of cardiovascular events, and you'll see why. But as far as in the studies, it wasn't necessarily used in patients who were having a PCSK9, who were currently using a PCSK9. It was just maximally tolerated statins. The way the dose is done is you get an initial 284 milligram as a single injection, and then you get it 3 months later, but then the maintenance interval is every 6 months. So they kind of advertise themselves as being the twice-a-year injection, but this does have to be injected by a healthcare provider. So they would have to go, even though it's not an infusion, they would have to go in to get this sub-Q injection. Those are kind of the main things with the injection and the frequency. So who could get this approved? Maybe a patient who had allergic responses to both Praluent and Repatha. They might be able to get this approved. Or if they, for whatever reason, had difficulty with the pen injector themselves due to arthritis or weakness of the hands, which I think is interesting that that's pointed out, because they could probably go in and have their healthcare provider inject those too if they were having those issues. But
I think I will say that this one you can specifically bill for the injection, and insurance companies will reimburse. Is like a
As a procedure,
yeah.
kind of thing.
I forget the actual code that they use, but you can actually, if once a company a clinic is registered to do this, or they have infusion clinics that you can go and actually get it injected as well. And so it just kind of depends on how it's set up. There's a few different ways of going about it, but there's a way of billing for it, so it does make more sense to bring them.
That does make sense.
At least you're getting paid for the time, whereas if you probably wouldn't get reimbursed, I would imagine, for a PCSK9 inhibitor.
Right, that makes sense.
In most cases.
As far as its data, the trials are the Orion trials, 9, 10, and 11, and that's how they got their indication for secondary prevention of cardiovascular events. I think it was Orion 10 and Orion 11 were both with patients who had active cardiovascular disease or were also at high risk, though they aren't making the recommendation towards patients who are just at high risk for primary prevention yet. As far as the reduction the patients got, they were only on maximally tolerated statins, like I said, no PCSK9s, but about a 50% reduction in patients who were already maxed on a statin. So that's pretty solid. I think probably similar to what the PCSK9s get. Yeah, anyways, I don't know if a patient on a PCSK9 could get this. I won't even say possibly because it hasn't been studied. But at this point, I think Evkeeza is the only one we've seen with patients who already are on that, and then we'll add on an additional one.
And I think the thought process is eventually going to be that this is a much better option secondary to a statin, better than ezetimibe, because you need a lot better lipid lowering ability. And I think the other thing they're trying to utilize is those patients who are at extreme risk for secondary prevention. So the ACE guidelines that have a LDL goal down to 55. That's much more achievable or realistically achievable with this versus ezetimibe or something added on. So I think that's going to be their kind of target demographic.
Yeah, that was a pretty big that they got that indication for secondary prevention. That's probably a pretty big deal for them.
Yeah, and there it is a whole process of ordering the drug and getting it set up to be injected. So I actually talked to one of the reps for it, and she was going to give me some information. It's very interesting. It'd be interesting to see how it plays out, but there's some lipid specialists around the area that are very excited about it. So we're getting close to time, but we'll. One thing I do want to mention that's just because we got a couple others to get through, but I'll mention briefly. There is another insomnia treatment option available. Most of us have all seen Belsomra and those orexin inhibitors that are orexin receptor antagonists that have been approved, but we have a new one now. So we have daridorexant has been approved, and it is in the same kind of concept as far as the others in this class, and the way to think about this one is it does tend to have the shorter half-life. And so one of the concerns with Belsomra and others is that the half-life is pretty long, and so you have to worry a lot about patient having residual symptoms the next day, grogginess, and all that kind of stuff. And so this one would probably be a good option to kind of make sure that it's out of their system, kind of moving forward in the morning, so that they're not having issues at work or fogginess, so to speak, the next day. It hasn't been compared to directly to one of our benzodiazepine receptor antagonists, or when we think of our hypnotics, Ambien or anything like that. Those are obviously still first line, but this could be a acceptable first line agent as well. And it's really something that if we're thinking along the lines of isolated sleep onset insomnia versus sleep maintenance or mixed insomnia, this is where that group of patients is where this medication can really be beneficial, because it is going to stay in their system for a while. So if it's difficulty sleeping through the night, so if after 30 minutes of being awake in the middle of the night you can't go really back to sleep, this is going to definitely help kind of settle the patient back down again and help them get back to sleep and maintain sleep. But we still can use our doxepin or our zolpidem or acipaclone, any of those, but this is another option that we have available to us.
Yeah, I'm all for new sleep options because I just still don't love any of the ones that we have as far from a safety profile, but
yeah,
sometimes you got to do them.
Got it.
So the next few that we'll talk about will all be for atopic dermatitis. So there's been a few that have been approved in the last year or so. The first that we'll talk about was from September 2021. It's a Janus kinase inhibitor, a JAK inhibitor. It's a cream. It's ruxolitinib, Opzelura cream. So it's for short-term treatment of mild to moderate atopic dermatitis. Patients have to be immunocompetent and older than 12 years old to use it. The studies that used it and that it was approved for were pretty short, usually about 8 weeks at a time for the time period, so we don't really have any long-term follow-up data. The side effects that we've seen are pretty mild, burning and itching at the application site, but it does have a box warning for some serious infections. Tuberculosis, fungal, viral, bacterial, and also potentially increased risk of lymphomas. Most of that data comes from the oral JAK inhibitors like Xeljanz, but yeah, we've gotten a few options for atopic dermatitis, and that is the cream option.
And I think, actually, I messed you up on that, Cole, because I think the box warning only applies currently to the oral option.
So this one does not have that.
I messed you up on that. It's totally my fault.
I got
you. But there's still something that they have to kind of monitor for long term, and it's an option that's, if you're going to use a janus kinase inhibitor, I think this would be probably a better option than some of the oral agents because of
less systemic.
That risk of systemic infection risk. But burning and pruritus we're commonly seeing those still. There's also, speaking of atopic dermatitis, there's also a new sub-Q injection available that got approved in December 2021. It's an Interleukin-13 Antagonist called Adbrevy. Gosh, I'm butchering these words today, man. AJ, I need you to
They are really, I think they're running out of easy-to-pronounce brand names, because usually the brand name's pretty reasonable, right? But to add a D before a B, it's just begging for a mess.
It's cruel, and then there we go, right on the podcast.
Cruel and unusual.
So if you guys are like, man, these guys sound like idiots today, sorry. You're not wrong. But this was studied as monotherapy as well as in combination with mid-potency corticosteroids, and specifically they used mometasone furoate 0.1%. One thing that it was effective as far as reducing treatment and whatnot compared to the placebo, but one thing that's interesting is you saw cases of conjunctivitis. Was 2 or 3-fold more common in patients receiving Adbrevy, I still can't do it, compared to those receiving placebo. So that's kind of an interesting thing to kind of keep an eye on and see how it plays out, because that's something that they mentioned a few times in even an up-to-date and things like that, where they were talking about the kind of their interpretation of the studies, and they brought the conjunctivitis piece up as well, because that could be a problem.
Yeah, that could be. The last atopic dermatitis one that is the most recent on the block, just a couple months ago, is Sabinco Apositinib. It's another oral JAK inhibitor like Xeljanz, approved for moderate to severe atopic dermatitis. And they actually put it head-to-head with one of the pretty common medications for atopic dermatitis, Dupixent. They compared the 100 milligram abrocitinib versus 200 milligrams versus Dupixent versus placebo. And the EASI 75 response, which is like a response they use to kind of gauge the severity of the atopic dermatitis, was observed at week 12 in 70%, 59%, 58%, and 27% of the participants respectively. So that 100 milligram Sabinco dose did seem to be higher than the rest of them, so that's positive for them.
Which is kind of weird.
Versus the 200, I don't really get it.
Yeah.
So yeah, probably something going on there that might be worth looking back into.
And that's where that box warning comes into play.
Yes.
So they're gonna, and this was approved for RA a while back. So I think that's where the box warnings were added in, I think in 2021.
Yeah.
And so it carried over obviously with this, but it'd be interesting to see how these JAK inhibitors are going to play out, because I feel like a lot of people are staying away from them and for different rheumatoid conditions and whatnot.
Right. I will say that I see it a lot for atopic dermatitis.
Do you?
I do.
For this particular?
No, JAK inhibitors in general. Dupixent is probably the most common one that I see. But I don't know how, I don't work in that space as much, so I don't know how this is going to shake that up with these new ones. But yeah. But yeah, the box warning: serious infections, major cardiovascular events like heart attack and stroke, possible cancer, thrombosis, death.
Yeah.
So.
Yeah, and I always think Dupixent's the one I see the most too. That one being an interleukin-4, I think that one's I'm not worried as much about the infection risk too, and I think that's still, because and again, this is all kind of not new as far as the labeled indications for atopic, but I'm wondering, because I feel like with a lot of the rheumatoid conditions, they look like they're not as effective as like the TNF alphas or the non-TNF alpha biologics versus those. It just seems like they keep getting pushed down the pecking order. So kind of curious to see how they play out, but we'll see. So I know that was rapid fire, guys.
That was a lot of info, wasn't it?
And I hope we didn't butcher some of those things too bad or confuse you with our going through it too fast. But we're only on a time crunch, so I think I'll put a list of the medications in the show notes as well. So for those of you listening that if you want to get a list of them and look up more information, I'll have those listed out in the show notes. So, and when I say show notes, just for those of you who are not familiar with that term, it's whatever podcast platform you're listening on, whether it's Spotify, iHeartRadio, iTunes. If you go and click on the episode and then there's all that information below it, if you scroll through that, that's got all of the information when I say show notes. So I've gotten a couple emails from that, and some, I think.
Where are the show notes?
Yeah, or where's the password or things like that, which is totally cool. I appreciate you guys checking it out. So I recognize that not everyone is avid podcast listeners. So I appreciate for those of you who are new to this space that, giving us a chance to checking it out, especially for getting your continuing ed. So thank you guys so much. Huge thank you to Free CE once again. It's been awesome partnering with them and being able to offer accredited episodes so that you can hopefully get your renewal, your license renewal with just listening to podcasts on the way to work. So thank you to them. Make sure you check out, again, their whole library of information that they have available on their website. Cole and I both use them ourselves and then definitely utilize some of their other content that's not created by us. And, some really good stuff on there. So check that out. Thank you to Pearls, and make sure you check them out as well, pearls.com/coreconsultrx. And if you guys have any questions for us specifically, show notes will be or the emails will be in the show notes. You can reach us on any of the social media platforms. If you want to send us a text directly, 415-943-6116. And make sure you check out the Patreon too. So it's www.patreon.com/coreconsultrx. We have like traditional style lectures and downloadable PowerPoint slides and all that. If that's more your speed. It gives you a little bit more of a traditional look at the information. And you can download the PowerPoint slides and rip them off if you want to. So it's like $3 a month. You can steal all of our content and then discontinue the service. Go for it. It is what it is. But I hope it's helpful for you. But thanks so much for those of you who have been signing up on there and supporting us that way. That's helped out a lot as well. We will definitely keep trying to improve and make stuff better for you and keep producing content that's useful. So thanks for everything. We'll see you guys in the next episode. Have a great one.